Okay, Vittorio, you and I don't get to talk face-to-face very often. We've collaborated for many years now, mostly by email and Skype. When PDM-1 had been out for a few years and Stanley Greenspan, who spearheaded that, had died, I thought there would not be a PDM-2. And somehow from Rome you decided that you were going to take on this mammoth project. So I'd like to know a little bit about what you were thinking and how it's come out for you.
When I saw PDM, the first edition of PDM in 2006, when it was published in the United States, and I realized I want this book translated in my language for my students, for my colleagues. And so with Franco Del Corno, my Italian colleague, we started to organize the translation, and we edited the edition that was out in Italy in 2008. Mm-hmm. Then I started to use it for teaching and for making diagnosis with my patients, for supervision, and I realized how interesting and important it was, more than using it, more than translating it. I realized. I remember that the Destiny wanted that we met each other in 2011, I think. I said, quite in a naive way, are you going to make a second edition of PDM? And I said, I can take this thing on, but I want you will be my guardian angel, do you remember?
Yes.
And probably with this idea of the guardian angel, you said yes. And so we started to work on this second edition. It was 2011, and we finished it in 2016, so 5 years of work, collecting a lot of people all around the world, many changes, more international task forces, more dialogue between the research part and the clinical part of the manual, more attention to specific moment of the life cycle. So we split the children and the adolescent chapters. We introduced the elderly chapter. We added clinician-friendly tools. And in 2017, it was out. Why I wanted to put all this energy in this project? For two reasons. I wanted to do something with your culture, to mix a little bit of European, Italian, and American clinical and research components, to put them work together. And the other reason, I think that I felt that PDM was really filling a gap in in our professional work, because our students, when we say diagnosis, they always think to DSM, or they think to a sort of magical idiosyncratic operation done in the secret of their own thoughts about the patient. So I think that PDM could be something structured and organized and operationalized enough to be a common language, but at the same time something of specific and respectful of the single patient, of the single person, that can be useful for people that when go for their therapies want to be considered not just as part of a cluster of people, but as someone specific with his own or her own history, relationships, values. And this capacity the PDM has to link the general and the particular, the nomothetic and the ideographic, makes it its value. So I think that the idea of working for a manual that gives to our colleagues the idea that the diagnosis has to be a torment for the clinician, and the meaning of the phenomenologist Karl Jaspers used to say was important. Torment in the good in the good meaning of this word, because when we say that diagnosis is something that has to be torment, means always that has to be always in dialogue with the treatment. So in your work, diagnosing a patient is something is like a preliminary condition for the treatment, or is a work in progress?
Well, occasionally it's a very important preliminary condition. For example, when you pick up that there might be brain damage in this person, and so you might need an intervention that has nothing to do with psychotherapy. I've seen a few cases in my career where people were treating something as if it were a conflictual issue, when in fact it was a matter of the hard wiring being a problem. So occasionally an early diagnosis will pick up something that makes a huge difference. And picking up, for example, a bipolar illness is not a trivial thing in the very beginning. But having said that, I would say that diagnosis is otherwise always ongoing, it's always becoming. I studied ancient Greek in college, and the origin of the term diagnosis means to know through, or to know thoroughly. And all we're trying to do as therapists when we try to diagnose is understand somebody, and that never ends. Someone told me that Anna Freud said that treatment ends, but diagnosis goes on forever. And I agree. No therapist has not had the experience of thinking suddenly after a couple of years of treatment, wait a minute, I've been thinking this person is dealing with, let's say, Oedipal issues, and all of a sudden we're in this pre-Oedipal area. Or I've been thinking this person mostly uses dissociation, but now I'm seeing that they rely a lot on another diagnosis or another defense mechanism. So we're always learning. We always have to be open to the possibility of being wrong or being corrected. And I think the diagnostic process is always a collaboration between the patient and the therapist. It's not something that the therapist applies to the patient. It's an ongoing project.
I would like to ask you to explain more in detail in your specific writing of the PDM, that was the personality chapter, the adult personality chapter with Jonathan Shedler, which were the more controversial issues, and how did you elaborate those issues in the moving from PDM-1 to PDM-2?
Well, about controversial issues, one of the surprising things in both PDM-1 and PDM-2 was how little controversy there was, given that psychoanalysts, if you put a bunch of them together, you put 3 together, you get 10 different opinions. But a couple of the controversial things involved a favorite issue of mine, which is it useful to think in terms of a psychotic level of personality organization? When we did PDM-1, some of us wanted to put that in, but Jonathan Shedler and Drew Western were a little bit uncertain about it and advised against it because they thought it was confusing to people who had come to see the word psychotic as meaning schizophrenic or manic psychosis or paranoid psychotic disorder. They thought it would be confusing, and we didn't have any empirical literature to resolve the question. But since then, there has been some empirical work by Robert Bornstein and Robert Gordon showing that clinicians, and not just psychodynamic clinicians, find it very useful to think in terms of there being a psychotic range of personality organization. Because to a clinician, the difference between, for example, the obsessive compulsive man who's at a neurotic level of organization who comes in and says, you know, I'm a bit of a control freak and I think my relationships are a little bit deadened by the fact that I have trouble accessing my affect. That kind of a person is easy to help. But then there's the obsessive compulsive guy who meets exactly the same DSM criteria, but he completely believes in all his obsessions, which are bordering on psychotic delusions. He believes that if you take them away from him, he suffers terrible annihilation anxiety. He's been this way his whole life. He doesn't see there's a problem with this. If you try to do exposure therapy with him too early, you get massive resistance, for example. And one of the problems we face now is that much of the research on specific therapies for specific problems are done with people at the high end of the spectrum. But clinicians mostly deal with people at the lower end of the spectrum. So the cherry-picked subjects of many empirical studies don't represent the actual clinical practice. And if therapists don't have the concept that you can be not schizophrenic, but psychotically organized in the sense of having some problem joining with consensual reality, being very self-referential, using very primitive defenses, having a lot of annihilation anxiety, having some mild thought disorder. If you don't have that category, then you're always going to be demoralized because you're not going to be helping your patients as fast as you think you should, given what the research says should be possible. So I'm glad we have that level now. Another controversial area is that I have tended to prefer to see borderline psychology as a level of organization. But there's a good counter-argument that, especially in the aftermath of the DSM, which made it a category, that it can be thought of as a categorical concept as well, a type of personality. We added a type, the borderline type, partly on the basis of the research of Shedler and Weston, which found that clinicians think in terms of that type, not just in terms of a level of organization. That was a big change that had been somewhat controversial. Other changes weren't so controversial, we organized the order of things a little differently based on externalizing versus internalizing psychologies, again based on some empirical data. We added a little bit more homage to Sidney Blatt's really important sense of a polarity between the communal and the individual. We didn't quite know what to do with masochistic personality, and I'm not sure we've quite solved that yet. And there are a few other issues that we talk about in the article that I did with Jonathan for the Psychoanalytic Psychology, where we feel that things are up in the air. Is passive-aggressive a type of personality, or is it a trait? Probably in some people it's one, and some people it's the other. Same with hypomanic personality. Is it a subclinical mood disorder, or is it a personality type, and so on. So, you know, it's the PDM itself is also in process. I want to ask you, now that it's behind you, this extraordinary collaboration of people, all of whom did it out of love for no money at all. All the royalties go into a fund that we're starting to develop mechanisms to give grants out of for research that will be helpful to clinicians. But now that you've jumped off and gone into the deep end, what surprised you?
The one thing that surprised me a lot, it's how many things you can find once you open the big box of diagnosis and you consider diagnosis not just saying present, absent, but something really that its diagnosis at the end of all is a meeting of minds. And so approaching diagnosis in terms of different moments of life like is PDM2, 0, 3, 4, 11, 12, 19, the adult, the elderly. Surprised me in terms of how many different approaches, different languages, how the same aspect, element of personality or of a mental capacity can be described with different words, with different exemplification. So this finding so many differences in the same contest, it was a surprise. And other surprises came when the manual was published, already published. And the first one is the gratitude and the interest we found. Well, we can say that it was a big surprise that after 1 month PDM2 was out, we had so many requests for translations in other countries, from China to Turkey, from South America to Poland. We make a lot of joke about PDM3, but at the moment we are happy with our PDM2, and I think we will have to create moments of training, panels, research, because it's important to use the PDM2 for empirical research, because our conviction is that the clinical work needs research, and the research needs a clinical work. So that's important, and the PDM moves in that direction, and so we will work more and more in that direction.